Hello, and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. Now, with that being said, in this episode, we discuss robotic simple prostatectomy for men with urinary symptoms due to an enlarged prostate, also known as BPH. In prior episodes, we've discussed several options for BPH, including medications and a variety of procedures. But what if the medications don't work and the prostate is just too big to qualify for minimally invasive surgical procedures? Fortunately, robotic simple prostatectomy has emerged as a potential option for men in just this situation. But how does this procedure work? What are the risks? How long is the recovery? And how successful is it, in relieving urinary symptoms of BPH for the long haul? To help us answer these questions, we are fortunate to be joined by Dr. Daniel Yoon. Dr. Yoon is a professor of urology and the director of the Robotic Urologic Surgery Clinical Fellowship Program at the Lewis Katz School of Medicine at Temple University. He is also the chief of robotic surgery and the director of minimally invasive robotic urologic oncology and reconstructive surgery at Temple University Hospital. Aside from performing over 1,000 robotic surgical procedures, Dr. Yoon has also extensively published peer-reviewed journal articles, book chapters, and video teaching guides, and travels nationally and internationally as an invited lecturer to present research and to train robotic surgeons. And now, without further ado, I bring you our conversation with Dr. Daniel Yoon about robotic simple prostatectomy as a treatment option for men with BPH. Hello, and welcome to the Better Man Clinics. Today, we're going to be talking about robotic simple prostatectomies as a treatment option for men with urinary symptoms from BPH. Now, in prior episodes, we spoke about other options for BPH, including medications, as well as surgical treatment options. But what if those medications don't work? And what if your prostate is just simply too big to even make any of these other surgical procedures a possibility? Fortunately, a newer procedure, again, called simple robotic prostatectomy has emerged that can really help men in exactly that situation. But what's really involved with this surgery? What are the risks and side effects? And frankly, does it really work? In order to answer these questions, we're really fortunate to be joined by a true expert, Dr. Daniel Yoon, who's both a professor of urology and chief of robotic surgical services at Temple University. Dr. Yoon, welcome to the program.
Thank you, Oleg. Thank you very much for inviting me. This is a topic that I love to talk about. And so as you'll see, I'm pretty passionate on this topic. Thank you for inviting me.
Absolutely, absolutely. Yeah, on that same note, before we jump right into the topic, one thing I like to do on the podcast is just to get a little bit better acquainted with our experts, so our guys know who they're dealing with for sure. And one question I'd love to ask you is: there's a little bit of a question out there about what really robotic surgery even is. Is a robot operating on me? Is this like the Jetsons, or what is that really like? So if you can share a little bit about, in general, what robotic surgery is and what drove you to really become an expert in that field?
Great question. So I would say to the average layperson that doesn't really understand robotic surgery, the robot is not autonomous and working on its own. If you want to think like drones, we talk about drones a lot these days. There is somebody that is operating the machine. It is precisely guided by the operating surgeon, but it is a way to operate a fancy piece of equipment inside a small or closed space, i.e. your abdomen, without having to put hands in there. And because of the electronic interface between the surgeon and the robotic arms that are inside somebody's abdomen, we are able to do apply very, high-end technology, energies, sophisticated movements into a very tight space that otherwise would be very difficult to do. I originally got involved with robotics because I was a Philadelphian that moved to Detroit for my residency. But what really unfolded in Detroit during those years was the earliest days of robotic surgery after FDA had approved this equipment, and the Da Vinci robot, which is the system that we're using, and there's multiple iterations and generations of this technology, was really the first series of patients were really done in Detroit. And so I guess you could say I was at the right place at the right time, and I caught the fever, I guess.
That's awesome. So you were really a trailblazer in robotic surgery, which is fantastic. And I think, like just like with the autonomous cars, people have a little bit of skepticism about fully giving up everything towards the machine. So I think there's a lot of comfort knowing that there's a skilled surgeon on the other end of the table and as part of the equation. Now, I think a lot of the guys who listen to and watch this podcast, they're familiar a little bit with kind of the concept of prostate surgery for BPH. And usually what that has in common is, there's some type of camera usually inserted into the penis. I always talk about the prostate as a big donut. And during these BPH procedures we discussed, you kind of shave the donut down using different energies, whether it's electricity or laser or whatnot. But robotic simple prostatectomy is very different, is it not? What is that exactly?
Yeah, so simple prostatectomy is instead of going through the penis and going through the urethra, we're going through the abdominal cavity, and there's several different ways that have been described. It's like if you wanted to go into your garage, I guess one way would be to go in through the garage door. And I would describe that as like doing a transurethral resection. But there's also a way to go into the garage through the front door or through the kitchen side door and going through the house and going to the garage. And so we get to the same place through a different means and through a different way, with the endpoint of the operation being very similar to get the adenoma or the prostate blockage out of the way. And that's primarily the difference between going transurethral versus going robotic.
Got it. And in that scenario, what's the advantage, I guess, of going trans abdominal, meaning the robotic approach? And is that advantage specific to specific types of patients with specific prostates?
Yeah, so for men who have an enlarged prostate, what that means for most people is that you may have a 20, 25, 30 gram prostate when you were younger, and it gets enlarged and it goes to 35, 40, 50, 60 grams. And that's the majority of people. And most of those people would be great candidates for a transurethral procedure. And there's many derivations of, there's versions of that operation as well. And those are appropriate patients. And so I don't think that we are trying to look for patients to do simple prostatectomy on that have those size prostates. What we're looking for are people that have supersized prostates, people who have 100 plus gram prostates that are 3, 4, 5 times larger than the average guy's prostate. And so what the American Urologic Association and the European guidelines, they all kind of recommend a different type of procedure for people with, I guess you would call them super enlarged prostates. I would say generally about 100 grams plus. There's also people that also have these enlarged prostates and that have a lot of other concomitant problems at the same time, which would be, bladder diverticulum or like blowouts of the bladder that we could at the same time remove those, blowouts and restore the spherical shape of the bladder so that they can contract and generate a normal pressure. And then there's also some people that just have inordinate stone volume in their bladder or very large stones that are very easy to just literally pick up and just put into a bag at the same time while we're doing robotic simple. And so there's a set of people that I would say are great candidates for robotic simple prostatectomy. And then there's a different population of patients that are great candidates for a transurethral procedure.
Got it. No, that actually helps a lot. Now, taking aside the diverticulum or the outpocketing, taking aside the stones, if you just have a guy with a really, really large prostate, 100 grams, which, probably 3 times normal, 200 grams, 6 times normal, what is the, and not to get too technical, but why can't you do the same procedure transurethral, like a TURP or a Roto-Rooter for those super large prostates? And what does the robotic element, how does it make it easier or more effective, I guess, for those men?
That's a great question. So, what I'll say is that urologists are very determined people, and if you are determined to do something one way, you can find a way to do it. And so, I think that there are some people that are very good at transurethral resection, and they may even be willing to come back for a second session and maybe do one side and then do the other side and do a complete resection. But I think that the reason why those guidelines are in place is that it's very difficult when the prostate gets to a certain size and much larger to be able to really adequately get enough of the prostate resected down, mowed down, so that you can really bore out the prostate to give a good result. And really one of the big things about these type of operations is that if you talk to men, they don't really want to come back for a second procedure.
Sure.
They don't want to come back and maybe do something in another year. We're looking for durability of our results. And so I think that when we're talking about these especially large glands, what we'd like to do is get efficacy. We want a good effective result, but we also want a durable result where enough is resected, enough is taking out, so that hopefully we'll never have to come back for this person again. And that's really the attraction to these type of more complete procedures.
Got it. Just one and done, basically, rather than kind of having to kind of futz around, if you will, over and over again to try to whittle this down to the right size.
Exactly.
Now, that being said, are there any men who couldn't or shouldn't have a simple open prostatectomy, like contraindications to the procedure?
I think that anytime you go in through a transabdominal procedure, you really have to individualize who you're operating on. I mean, there are just some people that just simply won't qualify based on either just very old age and frailty, or they have, cardiac conditions very severe that their cardiologists do not think that they're good candidates for. People sometimes they have mechanical heart valves and their blood has to be super thinned out. And those people may not be the most ideal candidates. So we have to really take it on a case by case basis. I have operated on people very old and somewhat frail, but it's a very individualized question, and it's a question of risks and benefits. And so I've taken people like even in their 90s for this operation because they were told otherwise. This was the only way they were going to live out their life with a catheter. And I told them that I thought that they were healthy enough, well enough to still undergo a procedure, and they've done quite well. But I think that you have to very carefully look at this, and it's not just men with small prostates, but people who have individual medical conditions that would make them really intolerable risk to undergoing a procedure. For example, like you've had a lot of abdominal surgery and a lot of mesh down there, or you have Crohn's disease. You may, we may have to have a long conversation about risk versus benefits in those people, and we may ultimately still proceed with surgery, knowing those risks. But some of those people will wave off and say, "We really don't think you should have this."
Got it. And so, speaking of risk, so if I'm a patient coming to your office and I'm saying, Dr. Ewan, you know what, I'm interested in this surgery. Can you tell me what risks are there to this surgery?
Excuse me. So I think that first of all, abdominal access and getting your instruments through the abdominal wall and into the prostate to work on the prostate, that pathway can be a source of a complication, right? And so if somebody has multiple prior abdominal surgery, prior radiation from prior treatment for rectal cancer, somebody has Crohn's disease, has had multiple bowel resections, a bowel injury inadvertently could be a problem, right? And so that is potentially a source. Bleeding, this is an operation that historically the open simple prostatectomy has had a very high transfusion rate. If you look at a study that was done over 10 years ago, and it looked at primarily open simple prostatectomies, I mean, there was, I think, close to like a 30% transfusion rate with open procedures. And the push towards doing this minimally invasive and robotically has drastically reduced this. And so I would say that bleeding in our series, when we looked at our last set of 200 patients, it was down to about 3%, which is, on orders of magnitude lower, right?
Yeah.
I think that's fair to say. The other risk that we see probably most frequency for this operation is urinary tract infections around the time of surgery, right before surgery or around the time of surgery or shortly after. And I would say that one of the reasons why that is the case is that a lot of about 40% of our patients came in with indwelling catheters, and some of these guys for years, right? And so you live with foreign body in your urinary tract, and we all, as urologists, know that that foreign body is colonized with bacteria, and these guys are living with dirty urine. And so in some cases we'll pre-treat with antibiotics, and it's just an inherent risk in this population. But for the most part, urinary infections tend to be relatively low grade complications that we see, and usually are treated with antibiotics, and these patients will then go on to maybe getting better after treatment antibiotics. But that is technically still a complication. And I would say that those probably are the biggest risks of this, or the most common risks, or the ones that we talk about the most about this operation, at least the way that I do it. And Oleg, there's one thing I want to kind of state is that we do a robotic simple prostatectomy differently than the traditional done prostatectomy, where and I think this is very technical, but we don't do this above the prostate like a retropubic or suprapubic, but we unzip the back wall of the bladder to get to the prostate, and then we run a full anastomosis between the urethra and bladder. It's a little bit hard and technical for the patients that might be listening to this, but because of that, our complication risks are actually a little bit different than traditional robotic simple prostatectomy, where it's done in a retropubic or suprapubic style.
Got it. So let's unpack that just a little bit there. So, a lot of times guys get confused between robotic cancer surgery of the prostate and robotic simple prostatectomy, and the side effects of those as well. Are there a lot of parallels between the two? And I guess what's the difference between if somebody went to you and said, Dr. Ewan, I need my prostate removed for cancer, versus I have a really large prostate and I need it operated on through a simple prostatectomy? Can you, at least on a high level, tell us what the difference between those two surgeries are?
It's a great question, Oleg, because I do a lot of both of these operations. So the most common operation I do robotic, that most people do robotic, is robotic radical prostatectomy. And when we say radical, it means whole organ removal for cancer, right? And so I like to make the analogy of a navel orange. And in the navel orange, you got your thick rind and peel, and then you got your pulp on the inside, right? And typically when cancer arises, typically cancer is involving near the periphery of the orange, if you will, near the peel or involving the peel, and then it pushes outward. And so when we do that operation, it's very important that we remove the entire orange. And when we do that, the things that are right outside the capsule or the outer perimeter of the prostate is what we're very keen on trying to not damage, yet still trying to remove completely so that we can get rid of the cancer. And the simple prostatectomy is a different operation. Although we use the same tools, very same incision and all of that, what we're doing is really trying to remove the pulp of the orange and leave the peel intact. And the primary reason for that is that the goal of this operation is to relieve obstruction, and it's not to remove the whole prostate. And so by leaving the outer portion of the prostate in, the two side effects of a radical prostatectomy that we're trying to avoid, which is negative effects of erectile function, and then two, causing incontinence or leakage for the rest of your life, are things that we are able to very routinely avoid by doing the operation to separate the pulp from the peel and leaving the outer zone of the prostate alone.
Got it. So basically, to that extent, the risk that you hear about often with radical prostatectomy, erectile dysfunction, and incontinence, you don't see those same type of side effects occurring after the surgery to that extent. Is that correct?
That's correct. We've actually gone back and looked at this very carefully. All the patients that we operate on, we include them into our database registry. We follow, the IPSS and sexual health inventory for men scores, and we pay attention to this because I think it's important. One, we are doing a new version of this operation. I think that part of our obligation when we're forging ahead doing something new is that we really have to track our results, and we have to show that we have at least show equivalency to the existing procedure that was there before us, right?
Hmm.
Which was the open prostatectomy or even the prior versions of the robotic simple prostatectomy. But what I could say is that as we look back at our data, we definitely do not see a significant change in our sexual health inventory, or erectile function quality. And we have, there may be like one or two patients in our series that may have a little bit of incontinence that may have to do more with bladder dysfunction, but we do not see stress urinary incontinence as a side effect of this operation. And I think that's a very, very strong reason why we have so many patients that travel a distance and come to us after doing research, is because if you ask men in this population, what is your biggest fear? It's really not abdominal incisions and abdominal recovery. It's I don't want to become incontinent.
Right. Of course. No, that's a huge one. And to that same extent, this is kind of comparing apples to oranges, not to take your orange example, but just comparing apples to oranges a little bit here. If guys just to use TURP as a gold standard, obviously TURP is not appropriate for these big prostates, but they're familiar, they've done research, they know what the quote unquote list of side effects for TURP are, how often they are. How does the side effect profile in terms of not abdominal, but just purely urinary side effect profile match up to TURP? Is it about the same for robotic prostatectomy? Are there unique ones that TURP wouldn't have? How does it match up for guys to understand?
So I'm going to answer this a little bit carefully because we have not directly looked at our data series and compared directly with URP. So I can't say this was statistical significance, right?
Okay.
By looking at this properly. But what I'll tell you is that that although this is an abdominal-based procedure and this is a bigger operation for them, there's something about us when we realign the bladder back to the prostatic, or the urethra, and we bypass through the prostate, right? And so we're basically taking two ends of the plumbing, and in between is kind of all the area that's been disrupted, right? And that's all a potential bleeding source. And we're pulling good end of the urinary plumbing back to the good end of the urinary plumbing and running a full 360-degree replumbing stitch, right? And this is the first time this has ever been done. This technique that I do, the version of a robotic simple that I do, is the first time that's really ever been done. If you look at all the urologic procedures that we do for BPH, none of them do that. And so it's been interesting to watch and see what's going on with our patients. And we get a lot of patients that anecdotally tell us, gee, this was easier in my recovery than my prior TURP that I had, 10 years ago, 15 years ago. And we get a lot less complaints about the irritative symptoms afterwards. And although I don't have data to back this up, my theory on this is that we all, as urologists, understand that urine is irritative, right? And urine is an irritant, right? And so, when we do these type of procedures, I think the urine often sits and bathes in this fossa, the area where the BPH used to be.
Sure.
And now it's still connected to the urinary tract. And I think there's something really good that happens when we realign the urinary tract and bypass the urine off of all of those nerve endings and all that sensitive area that affects, like when we looked at the laser KTP series, we saw that there's a lot of irritation. Right. Right. And that's really the reason why many urologists backed off of that procedure over time. Right. And I think all that energy that's being applied into that fossa with all the nerve endings and then the urine sitting there afterwards was really the reason why a lot of those patients had those irritative symptoms and that urgency and frequency after the procedure. And what I'll say is that very strangely, we don't see that. And it's really remarkable. And so a lot of these patients, I would say, of the group of patients that I have that I operate on, these are the happiest, I guess you'd call my biggest fan club, the guys that I get the most hugs from. We play this game with the patients where they say, you got to come up with a good one-liner after the surgery. And they'll say, like, I had to hold on with two hands or else I was going to fly away. You know, I can roll a can up the hill when I pee. You know, I go out with my grandkids, you know, and when we play this game where they all try to outdo each other with and really what it is that we find a very reliable quality of life and happiness that comes after this operation that is a bit unusual, and we kind of still, you know, are taken aback by it. But I think it has to do with not just removal and relief of the obstruction, but somehow realigning that urinary tract does something really good for them. It's hard to study.
It sounds like it. It sounds like it's a very rewarding procedure to do, to see some happy campers at the other end of the tunnel there, which is fantastic. Now, one thing I want to do, because the one thing the guys really like about this podcast is we really kind of take a deep dive into the experience, right? In terms of kind of really the logistics of how this process works from the patient standpoint. So the first question I'm going to ask you, just again from this logistics, is if I'm coming to you, you know, I suspect that I have a really large prostate, maybe my primary care doctor referred me or my urologist referred me. Do you need to do any special evaluation on me to confirm that I'm the right candidate for you, or just in general as part of your routine evaluation? What should I expect as a patient in terms of evaluation?
That's such a great question. Like, you know, so when we're looking at these patients, and we have such a huge, diverse patient set, we got patients who get on a plane and fly across the country or come from a different country for this procedure. And then we've got people that drive 2-3 hours away. We're in Philadelphia. They may come from Cape May, New Jersey, from Dover, Delaware, from, you know, even upstate New York or Northern Maryland. They come in quite a ways, and they may get a hotel overnight. And then we got our local patients that are from the city. And so we really don't, we want to be efficient. We don't want to waste their time, right? And so I don't want these, especially these older patients to really struggle with coming in and then have to bring them back multiple times. So the things that we look for very carefully is, one is to try to get a reasonable assessment of prostatic size. And so we're often doing calculations, you know, a prior transurethral, transrectal biopsy. Some of these guys have elevated PSAs, you know, so we'll look at that information. We'll look at MRIs, or sometimes we'll just literally have to do a size assessment on the table on some of these patients with a transrectal ultrasound. So there's a lot of different ways to do it. So one is we're trying to get people in the appropriate prostate size. And we think that that's very important. The other thing is that this is also in a very similar space as men who end up with prostate cancer that are in the age that need to be discovered and treated.
Sure.
And so we try to be very kind of thoughtful and careful, but not make it mandatory as we have a discussion about elevated PSAs. You know, a lot of guys in this age group that don't have prostate cancer still have elevated PSAs due to urinary tract irritation, recent catheterization, and just simply just having a huge prostate. You know, you can have a PSA that runs 6 to 10 to 12, you know? And so what we try to do is very responsibly try to recommend the appropriate people to go get a biopsy. And when we feel strongly about it, there was a guy that came to us with a, you know, 500 gram, 600 gram prostate. And I really kind of had to argue with this guy to go get a PSA because he just wanted me to do this BPH procedure. And at the end of it all, after I did a radical prostatectomy on that guy because he ended up having prostate cancer, you know, we hugged and he cried and he said, thank you, because I try to direct him towards the right thing, right? To try to do the right thing. And so just because I do a lot of BPH procedure and because I love to do this operation, I think the responsibility onus is on me to still try to do the right thing and guide these men so that when appropriate, they get a PSA, but also have a balance with that. Some of these guys, they feel very strongly they don't want it. They've been biopsied 3 times, and we'll negotiate that. And as long as they understand there's a risk that's entailed if we proceed without a biopsy, and they're willing to assume that, then we can also go on and proceed with this operation. So it's, you know, those are the main things that I'm trying to make sure that we cross those, you know, check those boxes before we operate on people so that we don't say after the fact, oh, we should have, could have.
Right. No, that makes a ton of sense for sure. Now, let's say again, you've evaluated me now in whichever mechanism, and we're ready to proceed. What preparation do I, as a patient, need to go through for the procedure? Do I need to take a prep? Do I need to do a bowel prep? Do I need to fast? What kind of things do you tell your patients to do to prepare for a procedure like this?
For the majority of people, it is like clear diet the day before. They have to go through pre-admission testing. And if they live, far away across the country, we'll work on getting all that stuff done locally for them. Right now, one of the hospital requirements is a COVID test 72 hours before surgery. So if you're from far away, sometimes it's a little tricky to do, but lately it's been easier than, a year ago. Um,
Sure.
and for, patients in this group, many of them have cardiologists or have cardiac issues. And so we need to deal with cardiac, clearance optimization. And then in some people, we need to get the cardiologist on board with anticoagulation plan. And so may need to take some of these guys off. If they really cannot come off anticoagulation, I would probably send them to somebody for a holmium laser
Mhm.
enucleation option as an alternative to this.
Got it. Got it. And then once we're at the surgery day, is this procedure usually under general anesthesia, or can you do it under sedation? What is it usually done under?
So this and like all, intra-abdominal procedures should be done under general anesthesia with an endotracheal tube and full with total body paralysis. And that's really the only way you can do this type of operation. Um, I would say, that we don't get a lot of questions and problems, about this, but I think it's important for the patients to know. The other thing is that the positioning, it's like radical prostatectomy. You go into a steep Trendelenburg, the head is down, and so if we think that there's going to be some technical issues, morbid obesity, BMIs, 45, 50, 60, we may have to wonder if this is the best way to go about it, and we may have to have a discussion about it and really include their cardiologist and things like that, because and some people just can't handle that position.
Got it. Now, you mentioned obviously you go through the abdomen. So how many little holes are you making, and how big are they usually? And where are they, I should say?
So 6 incisions. I basically tell people, if you had a belt, if you held, a 12-inch, 18-inch piece of string, and you put it across your hips with your left hand and right hand,
Mhm.
where that string lies is typically the line on which you'll get 6 incisions, ranging from 5 millimeters to 12 millimeters. And then the one that's above your belly button is the one that's extended or enlarged, where we capture all the pieces, any stones, diverticulum, pieces of the adenoma that we've now removed from your body. We drop it into the bag and we try to squeeze it out to the smallest incision possible. And so in most people, it ends up being maybe about 1.5 inches, 2 inches. But obviously, some of these prostates are very, very large, and so sometimes we have to make a palm-sized incision to get it out.
Got it. Got it. So yeah, you have to get it out one way or the other, right? That's for sure. And then again, just on a super high level, just to reiterate, you're going through these little incisions, you're approaching the prostate, you're potentially making a cut either in the bladder or the prostate to get exposure to the pulp of the orange, and then you're using that equipment to basically elegantly carve out that pulp, leaving the rind or the peel in place. Is that about an accurate description?
Yeah, that's a very accurate description. I would say the advancements that we've made, or the derivations that we've made off of this operation to do it the way that we do it at Temple, the way that we published on, there adds a couple other advantages. One is that a lot of these transurethral procedures, because the amount of blood that's coming from the area that mixes with the urine, a lot of urologists historically have put in 3-way catheters, which are big bore catheters with the ability to irrigate in and irrigate out and wash out the bleeding so that it doesn't form into a clot. And what
Mhm.
we found is that our patients, when we started doing it this way and realigning the tissues, we realized, we started with a 24 3-way and we slowly came down. Nowadays, we don't do any CBI or continuous bladder irrigation on anybody. So everybody gets a 2-way catheter, standard catheter. And we go down to an 18 French catheter, no continuous bladder irrigation required. And because of that, we're sending a lot of patients that are at least semi-local, regional, home on the same day. So roughly about half of our simple prostatectomy patients are going home on the same day from the recovery room. And a lot of the patients that end up staying overnight and going home the next day tend to be patients that are either very kind of older, maybe not as healthy, that we want to keep an eye on. And then the other population are patients that are done maybe a little later in the day, in the evening, they wake up slowly and they have a 2-3 hour drive to go. And so, obviously they feel uncomfortable. I don't want to tell the wife, to drive them, to Scranton, at 10 o'clock at night. So I tell them we're going to just keep them.
Yeah, but generally it sounds like either outpatient, home the same day, or the next day, usually at the latest, barring any unforeseen circumstances.
Correct. And then, there's also people that are just, some people are very gung-ho about leaving and some people are very nervous about leaving. And we don't try to make that into a big point. Look, we just want to take care of you. And so, if you want to stay, you can stay. It's not a big deal. But nowadays with COVID and all, a lot of patients are motivated to get out of the hospital if they don't need to be there.
Got it. No, that certainly makes sense. Just to backtrack for a quick second, how long does the actual procedure take to complete?
I would say in general, about 2-ish hours. Sometimes people are technically harder, they bleed a little bit more, we struggle a little bit more. So it could be longer. Some people have diverticulum. I mean, we've taken out, I think, as many as like 8 to 10 diverticulums and patched up the bladder in multiple spots on some patients. So, some of those cases can go fairly long because there's just a lot of work to do. And we're trying to, restore the bladder back to like what it was like 20, 30 years ago. So there's some work, but I would say on average, I did one of these cases in front of a live audience in Vegas a few years ago. And I would say that guy was ideal, skinny, he had 140 gram gland. And we did his operation in about 70 to 80 minutes. We were out probably about 100 minutes total anesthesia time. And the guy, was able to go home same day.
Got it. No, that sounds fantastic. You mentioned the catheter. The catheter is a point of contention for a lot of patients, a point of concern, I should say, for a lot of patients. It's really cool that you're actually using a smaller catheter. It's a lot more comfortable for sure. How long does that catheter generally have to stay in place after this procedure?
You're asking such a good question because this is something that I ponder all the time about. So, I think that we could probably pull these catheters out a lot earlier than we do. We normally keep them in for about a week, right? And for some people it's a big deal, right? The reason why I've been fairly conservative in this thing, in this decision point here, and leaving it in for about a week is that, I get a lot of urologists that refer to me, and what I don't want to do is have the patient show up in the ER because we pulled out the catheter too early, and I've had to pull them out of bed, and so I don't want to torture the guys that are referring patients to me, or even if they're not referring to me, I want to take care of my own issues and not make somebody else take care of it. So because of that, I have to say I've been fairly conservative, and we leave the catheter in for about a week and no less. Because a lot of these patients are down the street from me.
Now, when these catheters are in place, is the patient bed bound? Are they just have to stay in bed, or they can still kind of proceed with walking around and do stuff around the house with the catheter in place?
Yeah, I mean, even if they're in the hospital overnight, we want them ambulating in the hallway with their IV pole, and they'll hook their catheter bag up to the IV pole. We want them up and about. We really don't want them bed bound. I think that bed bound after urologic pelvic surgery is not a good thing, and we all, as urologists, kind of preach that to our residents. And so we want them ambulatory as soon as possible. Just no heavy lifting, no Valsalva maneuver, no straining your abdominal cavity. I generally say don't lift anything more than a couple gallons of milk for 6 weeks.
Got it. And that's via catheter or no catheter. Now, when this catheter comes out, how does it remove? Do they have to go back to the operating room? Is it done in the clinic? A lot of guys don't quite get how the catheter comes out, and is it going to hurt?
So I would say the majority of these catheters are removed by their referral urologist locally because they live far away. Because of COVID, especially during the heat of COVID, a lot of patients said, "Doc, do I need to go back into a doctor's office? Can I do it myself?" So we started actually giving people worksheets on how to remove it. It's very, I tell people, as you probably know this, a lot of patients are anxious over the catheter removal. And what I tell people, honestly, from my standpoint, it's like a glorified Band-Aid. You can either take a scissor and cut the end off and just pull it, or you can take the balloon down with a syringe. but it's really a non-event. I mean, it's like a happy day to remove the catheter, and it's not shouldn't be painful. It shouldn't be excruciating. I understand the anxiety behind it, but I would say that a lot of family nurses, physicians may pull their catheter out for their, instead of bringing them into the office. But if some patients are just nervous and they want to drive into our office for catheter removal, and we'll do it. We're happy to do it as well. But I would say to people listening to this, I understand that you may have some anxiety over it, but I would say that if you look at it from our perspective, you shouldn't really be anxious. You should be delighted that the catheter is coming out.
No doubt, no doubt. Now, two things that guys worry about once the catheter is out is, one, is it going to hurt to pee the first few 10, 20 times because of the irritation from the catheter and stuff? Is that something that you've heard from your patients once the catheter is out?
Yeah, that's one of the things that we have to pay attention to when people call us or send us text or emails, afterwards, because we also want to be careful that they don't have a UTI going on. Remember, I told you
Mhm.
that's one of the most frequent events that we see around the time after catheter removal. And so, I tell people, look, it's going to feel a little funny, peeing. It might sting, burn a little bit. Some patients will ask for peridium. We can give it to them. That's fine. But most people once or twice, and it really starts to calm down. If you're having a lot of irritation and problems, burning afterwards, we're going to want to set up a urine culture or urine analysis to make sure you don't have a UTI.
Got it. And another thing they worry about, this goes back to the radical prostatectomy versus simple prostatectomy. They worry, you've done a lot of work on my bladder and my prostate. When this catheter comes out, at least at the beginning, am I going to have trouble controlling my urine just from irritation alone? Is that something that you see, or are they pretty in good control of their urine right off the bat once that catheter comes out?
Yeah, I'd say for the vast majority of people, they're able to control their urine. They're delighted. They go, "Oh my God, I haven't seen a urine stream like this in a long time ago." And I tell people, like, it'll actually get better once there's some of the inflammation dies down. We don't have a lot of people tell us, incontinence issues. Now, there are a subset of people that have just severe built-in urinary urgency. And if the incontinence is there, almost every single time is an urgency related issue, right?
Mhm,
The bladder
mhm.
has just a lot of urgency built in. And when we look at our, on our studies, and we look at our IPSS, AOA symptom score, and see how they score, we definitely see for a steady 3 months, there's just a progressive drop in symptom score. And I think that that's a lot of that inflammation is dying down. And then, I think anytime you do a BPH procedure, there is like a weird 5 to 10 percent of patients that will either have de novo urgency issues that arise, or they will continue or persist to have urinary issues. And I think that's a bladder problem. So when I talk to people about what's going on in their bladder and prostate over the decades that's led up to this problem, I try to explain it to them as it becomes a 2-organ problem, right? It's a
Mhm.
prostatic obstruction, but it's also a bladder function problem. And we have to sometimes give a time for the bladder to calm down and realize, oh, I don't need to push so hard against this bladder, against this prostate anymore. And so in some people, we will put them on anticholinergics, or we'll put them on, medication to just calm down their bladder a little bit. But I'd say in the vast majority of men, that progressively and drastically, almost immediately gets better, starting from the day the catheter comes out.
Well, that's very reassuring for a lot of guys to hear. That's for sure. What a nice experience from that standpoint. Now, one of the things that again, one of the main things that's different about this approach versus standard BPH approaches, again, you're going through the abdomen. Now, does that mean that patients should expect to experience some pain post-operatively, aside from the catheter, just like abdominal pain that maybe they wouldn't expect to experience from a Roto-Rooter or whatnot?
Yeah, I would say that the vast majority of patients, if you see them or you talk to them the evening of surgery, on post-operative day 0, is that a lot of them will say, "I'm sore, but I'm not in a lot of pain. I feel like I did 500, 1,000 crunches. If I lay here perfectly still and I put my head back on the pillow, and I don't lift up my head, I almost feel nothing. But it's like when I try to get up, I feel soreness." That's what most vast majority of people will say. And although we send people home with like 20, Tylenol with codeine, we encourage people not even to take it if they don't need it. And the majority of our patients also don't want to take it because they don't want to get the constipation side effects a few days later. And so
Sure.
I would say a lot of our patients say they never took it, and a lot of them will just say they took the like a high dose ibuprofen or extra strength Tylenol, and that was all they needed. It was a little sore for about 3 days, and then they're fine.
That sounds reasonable. And you had mentioned in terms of restrictions, you said, no heavy lifting for a period of time. What about driving? Are they able to drive once that catheter comes out, or are they off of driving for a little bit longer?
Yeah, so great. I would say when the catheter comes out and they're off of all pain medications, they're allowed to get behind the wheel. On average, for most people, that's around 7 to 10 days. You can have not at the same time, but you can have a glass of wine, you can have a beer around that time as well.
Mhm.
You can shower 48 hours after surgery, and because we're closing with medical grade super glue and absorbable stitches, everything is absorbable except for the catheter. Everything is absorbable. There's no staples, or sutures to remove. There's no butterfly strips we need to take off. It's basically as soon as you're discharged from the hospital, once the catheter comes out, I mean, you're on autopilot. And so that's what the main instructions we give to people.
Got it. And then how soon do generally people go back to work after this? Is it 7 to 10 days like the recovery, or is it usually a bit longer?
I'll tell you, the physicians are the worst. Let me start off by saying that. I caught one of my physician friends rounding on the hospital with his team on post-op day one after I had discharged him. Like not an hour later, I caught him in the hallway rounding. I was like, "What are you doing?" Right? And so one is that I'll put that out there. Physicians are the worst listeners when it comes to being good patients. I think it really depends on the type of job that you have. We got guys that are heavy machine operators, big rig drivers. I tell those guys, you may want to take it easy because, when you're at work, you forget about yourself. You just want to get the job done, and then you overextend, right? And so
Mhm.
for people who have very physical kind of jobs, or people who want to go back to the gym, I say you want to maybe wait 6 to 8 weeks. And if you
Mhm.
can, please wait that long. Or if you can get back to work but do light duty, and you really have to be good with light duty, you can go back, you know, around 2 weeks. I generally encourage people to at least take about 2 weeks off um, from from um, from work. A lot of people have jobs nowadays. They're working from home, or they're doing paperwork. They're doing things on the computer. They talk on the phone. They're driving somewhere. I think for most of those type of people that have those type of non labor type of jobs that don't require heavy lifting and climbing up on ladders and stuff, I think two weeks is probably about average and fine for most.
Got it. Now, important question that we need to turn to or topic is efficacy, right? Do men who undergo this procedure, do they have to stay on BPH medications, or are they basically, if you will, quote unquote, cured in terms of their BPH symptoms with the procedure itself?
Yeah, so we tell people to the day of the procedure is the last day you're going to take your BPH medications. Just finasteride, dutasteride, any alpha blockers, stop all of it, right?
Mhm.
And I tell that uniformly to everybody. Otherwise, I mean, otherwise, we'd be saying that the procedure wasn't really complete. If you've
Right.
really done the right job here, you don't need those medications. You shouldn't be on those medications. Um, and so, as far as durability of it, I don't know. I mean, I've been in practice for about 14 years. I've been doing this particular version of the operation since 2013. I guess as the decades go fast forward, I'll see if there's any patients that need any kind of repeat treatment. But I tell people the intention of this operation is to be one and forever done.
Got it. No, that's reassuring too, because again, for the other procedures, particularly like the missed procedure, stuff like that, that's always a concern about, within 3 to 5 years or sooner, have to kind of get a tune up and stuff. But it sounds like this is much more definitive in terms of removing all of that tissue. Now, another thing that you mentioned is that, people are coming from all over the country to get this procedure with you and your team. The question is, how widespread is robotic simple prostatectomy? Do a lot of urologists do it around the country? Is it really one of those super subspecialized type of procedures? What are your thoughts on that?
That's such a good question. I lecture on the topic of surgical innovation a fair amount, because this is one of many procedures that I've innovated and I've created and pushed the envelope on. And one of the lessons I've learned, about surgical innovation is that a mark of a good operation is one that's teachable. It's it's replicated. Somebody can watch the video, go to the meeting, somebody who has reasonable skill set and should be able to duplicate that. I've handed off my videos to many a good robotic surgeons around the country. They've looked at it and said a year later, Dan, that operation is freaking awesome. I started offering to everybody. I love, what it does for patients. And my hope and wish is that this procedure will be the standard of care across the country, or in, countries that have readily accessible robots, to be the best version of the BPH procedure for very enlarged glands. Although, there's the population of patients that are willing to travel, there's still many pockets of the country that may not get this version of the operation, or may not even have robotic simple available to them. And so everybody has to kind of look and see what's available. You have to scrutinize your local surgeon to see if how many have they done, do they feel comfortable. But there's also people that come a distance and they're willing to go through that trouble and pay the extra difference because they want somebody who's done a lot of it. From time to time, I hear of some kind of major complication, like I heard recently of a rectal injury, that happened from a robotic simple, and it really pains me to hear those kind of things. But I think that that's probably the reason why, when people are looking at their situation, they're saying, well, I can go to a guy that's been doing this for a couple of years and have done 20 of them, or I can go to somebody in Philadelphia that has done like 500 of them, right? And does 2 of these a week, and so I think that's what that population that are traveling are looking for, is that there's more of a guarantee that the operation will go without a hitch.
Got it. And just in general, like, again, you've done, a gazillion of all these type of robotic surgeries. What is, in terms of learning curve? So like, if I'm a patient and I'm going to, my local urologist does robotics, and I'm going to vet them, and let's say, maybe I don't need to travel to Philadelphia, right? Maybe I can stay in whatever, Alaska, and this doctor says he does robotics. What's a reasonable amount of cases that a robotic surgeon should have under their belt for you to say, you know what, this guy knows or gal knows what they're doing?
Man, you got all the awesome questions. So one of the challenges, I say that this operation is a competing operation with holmium laser enucleation, right? So HoLEP. And one of the problems with HoLEP inherently is the learning curve is really steep, and a lot of residents that come out of those kind of programs, haven't actually done enough hands-on themselves, and so they may feel uncomfortable still doing it, and it's a daunting operation to do if somebody certainly not trained in it. And we train residents as well. So, there's some amount of experience that our residents and fellows will also get with me on doing this. And what I would generally say is, for somebody who has reasonable skill set, I think the learning curve is probably about 5 procedures,
That's a big
about
difference.
5 procedures, right? Which, when you really look at the state, at least let's look at the United States, the number of surgeons that have invested themselves to a great degree to learn robotic surgery and to get robotic equipment into their hospitals, I mean, it's pretty diffuse, right? And so the desire has already been laid down, the equipment is available, and so if the learning curve is pretty short and not daunting, then then you can readily start to make this available across the country. And that's what we're seeing, is that we're getting a lot of people around the country that have a lot of interest. They're watching these videos, wanting to get interested, and they're now starting to offer this to their patients, and I think it's great.
No, that is great. And again, that's the constant balance that patients need to take, right? They may, again, for men with really large prostates, as you said, they're really choosing between 3 things, right? They're choosing between a robotic simple, they're choosing between a HoLEP, the holmium enucleation. We recently spoke to Dr. Amy Krambeck about that. And some people may even be choosing to do an open simple prostatectomy, which I think, to my knowledge, is very rarely done these days, but I'm sure is done somewhere. And that balance is between finding the procedure that sounds best for them and also a surgeon that will do a good job at that procedure. And it's that balance that's probably one of the keys. But I think that what you've done today is really provided us a kind of balanced and fair assessment of the procedure, as well as kind of the risks and benefits. And I think really helps guys understand a real option that a lot of them may not even know existed. So thank you for that very much, Dr. Yuen. Really appreciate it. I'm going to end our discussion here with something completely unrelated to surgery or robotic surgery, anything like that. we pride ourselves here in Better Man Clinics to make people better, right? To make guys better. And that just doesn't mean just having surgery. And so you obviously reached a pretty significant level of success in your life, both career-wise and otherwise. What's the secret to your success? How do you live your best life?
Boy, that's I need to think about that one for a bit. I am somebody that religious. I have faith. I pray when I drive into work. I ask God to guide my heart, guide my soul, and to guide my hands, so that I can help as many people as I can. When it really cuts to the chase, what guides me, what is the secret to my success, is that I've been blessed by the good Lord. So thank you for asking me that.
Thank you. Thank you very much. Faith is key, right? Faith can really help quite a bit. Dr. Yoon, thank you so much for your time. Thank you for your wonderful insights. And to all of you guys out there listening and watching, thank you for joining us. And remember our mantra here at Better Man Clinics: your best life is a journey and not a destination, and use every single day to get just a little bit better. Thank you, and we'll see you next time.